Hi, welcome to Whiteboard Wednesdays. This is Dr. Inky Parrack talking about some expert opinion on what to do when you encounter the word endoleak from your doctor. It's a pretty scary word because you think you just got your aneurysm treated, meaning your aortic aneurysm is fixed. And then about a year later or multiple years later, you go back to see a physician and they say, you know, you have an endoleak. It sounds very scary. The myth is that most people think that there is something leaking outside of the blood vessel. It's collecting somewhere. Your blood level is coming down of your body. This is not the case. What endoleak refers to is that your repair is not holding as tight as it should be. And at the end of the day, now your risk of aneurysm rupture, which was now almost nil by getting it fixed, is now going back up to where it was before it got fixed. The level and the degree of that scariness depends on the type of the endoleak. So we're going to today discuss what that means, when to be a little bit scared, when it's okay to watch, and what it all means. So let's talk about what actually endoleak is. When you have your aortic aneurysm repaired, this endoleak refers to only when you got it repaired via endovascular means, which is what most of the patients go through these days. When you have an open surgery, your aneurysm actually gets opened up and cut, and then a fabric or a tube gets sewn into your body. And that's it. It's a much more significant and morbid of a procedure, but at the end of the day, once you've gotten it fixed, your complications are very different types, like infection, bowel obstruction, things that are related to more open techniques. The endovascular technique, which is where endoleak is one of the future complications that can happen, is done via fixating a tube graft up in this area where there has to be a tight seal between the blood flow here as well as down here so that no blood leaks around this segment into the aorta and no blood leaks around into this segment back into the aorta. So at the end of the day, everything has to be tight, tight, tight so that there's nothing in terms of blood going into your aortic sac. Once there's something going back into the aortic sac, that's called an endoleak, and now your aneurysm is again pressurized. So by law of Laplace, now there's pressure extension of your diameter sac, and it can then have a risk of rupture. So what do these fancy words endoleak indicate? It indicates many different conditions, some of which that you have to think about. The first one, which is most significant, is type 1 endoleak, which means the fixation point up top or down below that your surgeon had done in the past is not as tight due to either migration of the graft, which is pretty rare, or your aortic remodeling, meaning as you start to get older, your aorta can actually elongate within the same length in the body, and it becomes, in order to fit in the same portion of the body, it becomes tortuous to get to fit in. As it becomes a lot more tortuous, this fixation point is not as tight, and then it can loosen up a little bit. Or conversely, your aneurysm could extend, kind of start to dilate up in this area, so then now there's a room between your aortic endograft, which is a fixed size, and then your aortic aneurysm wall. So if the blood flow goes into that segment, that's a lot of blood going in through because it's the blood that is directly seen from the heart, both in an antegrade position as well as if this is not fixed in a retrograde position, that's significant amount of blood and that has to get fixed. You will also find some physicians or surgeons saying, you know, your endoleak is small and we don't need to do anything. Let's watch it. That means all the fixation points are okay, but despite that, we're seeing some blood that is going into the aneurysm sac. How does that happen? That happens because our bodies are miraculous. Our body normally has things like lumbar arteries and tiny little blood vessels that are coming out of the aorta that usually perfuses small portions. When this is occluded, our body does not like empty space, and our body loves to find a way and make new life. So then it starts back feeding through an opposite direction the blood back into the aortic aneurysm. And it is a complete opposite direction of what happens. And sometimes your body can make little new channels, and then your aorta now gets fed. And that's not something we can necessarily prevent because it's something that your body develops and adjusts over time. If the channel is just one little channel and if it's small, you do not need to get that fixed, and we can watch it, make sure that the aneurysm sac is not increasing. And it is initially, we wanted it to remodel, meaning shrink. So as long as it kind of stays in that same general sort of a size, then we have time to just keep an eye on it. Conversely, if your aneurysm starts to grow, that means that backflow, back channel, wherever it is actually significant. So then that has to be addressed. It can be addressed in multiple different ways, which we can also talk about in a separate Whiteboard Wednesday, but it has to either be plugged up or that space obliterated so that there's nothing else that can go in there. The third thing, which is actually pretty rare, and we see this unfortunately now and then, is that the graft itself, because there are many different companies, many different types out there, is a bit malfunctioning or dysfunctional and it tears somewhere. And if it has a hole in the graft, I mean, obviously now the blood flow is going to come in from here into the graft and then go out through the hole into the aortic aneurysm sac. That's something that could readily be repaired, readily be fixed by lining with a clean new graft. And so that's something that you should not wait to get that fixed. So this is the basics of endoleak. Sounds scary, but you still have time. Nothing is ruptured, nothing is bleeding out. It's just something that has to have maintenance so that you can have your aorta now again down below that level of rupture risk. Again, this is Dr. Inky Parrack on Whiteboard Wednesday. Thank you.